Hey everybody! Happy afternoon, morning, evening, middle of the night, who knows? Welcome to the yet another episode of the Generalist CCFP 105 Topics Podcast.
Today we have a bread and butter family medicine topic ready for you. That is immunizations.
Immunizations! And that beautiful angelic voice was Sean Wang, third year Dalhousie medical student out of Halifax, Nova Scotia. Beyond just writing the episode, but he also pulled in an expert reviewer, another East Coaster, Dr. Melissa Power, Dalhousie Family Med Staff and faculty undergrad coordinator of Southwest Nova. Thank you, Dr. Power. You were amazing.
This is a very large topic, and don't worry, we won't just repeat routine vaccination schedules to you the whole time. Rather, the CCFP objectives focus on more the nuanced details of vaccines, which we all need a solid grasp on.
And that was absolutely perfect because as we learned from our review course episode, they don't focus on anything unless it has a national standard. And we have a bunch of different provincial standards, so they're never going to test you on that. But you should know that depending on where you're going to practice. Should we do it?
Let's do it. Cue the music.
Objective 1. Do not delay immunizations unnecessarily.
Common encounter in the family medicine world is when there are delays from the standard immunization schedules that we've all grown to love. As is life, a patient might miss an appointment, resulting in a longer than recommended interval between doses of vaccines.
You might ask, are there any times we should consider delaying immunization in our patients?
That's a great question. We'll set aside the vaccine hesitancy as a reason for now, as that will be covered in Objective 2, but focus on the other reasons why immunizations might be delayed. First, although it makes sense to parents to delay their kiddos' immunizations if they have the sniffles, the National Advisory Council on Immunization inform us that there is no reason to put off immunizing kiddos with mild acute illnesses, including upper respiratory tract infections, otitis media, and mild diarrhea.
That's awesome because it's such a common thing that comes up. Immunizations also do not make symptoms of illness worse, but there are other moderate to severe acute illnesses that we might actually suggest that people postpone or defer their vaccines. These include things like
1. Gastroenteritis, postpone oral typhoid, cholera, and traveler's diarrhea vaccines until the illness has resolved. Defer rotavirus vaccine until condition improves unless deferral results in scheduling the first dose beyond the recommended age limit.
Also, measles. Delay varicella-containing vaccine for 6 weeks. So this means if the patient has measles?
Yes.
So in this case, a minimum of 4 weeks delay can be applied if needed.
And next up, medical attended wheezing in the 7 days prior to vaccinations. The live attenuated influenza vaccine is contraindicated.
So kid's been wheezy, he's been seen in the hospital for the same gut treatment. Don't give that then. Gotcha. If they have active or untreated tuberculosis, you got to keep in mind that TB might be exacerbated by natural measles infection, but there's no evidence that measles or varicella-containing vaccines have this effect. So MMR, MMRV, varicella, live zoster vaccines are contraindicated, largely as an academic precautionary measure.
Antibiotic therapy does not interfere with the response to non-live vaccines or most live vaccines, with the following exception.
The Typho vaccine series should be finished at least 3 days before you start antibiotics like sulfonamides or other antibiotics against S. typhi or antimalarials. Some exceptions are chloroquine, mefloquine, Malarone. Those are okay.
Individuals receiving long-term warfarin or heparin are not considered to be at a higher risk of bleeding complications following immunizations and may be immunized through either the intramuscular or subcutaneous route, as recommended by the particular vaccine product, without discontinuation of the anticoagulation therapy.
Keep in mind as well that antiviral therapy does not interfere with the response to non-live vaccines or even most live vaccines. There's a couple exceptions.
Varicella vaccine and live herpes zoster vaccine may have reduced effectiveness if given concurrently with antivirals active against varicella zoster virus, such as acyclovir, valacyclovir, famciclovir. People taking long-term antiviral therapy should discontinue these drugs if possible from at least 24 hours before administration of varicella or the live herpes zoster vaccine, and should not restart antiviral therapy until 14 days after vaccination.
And then the live attenuated influenza vaccine should not be administered until 48 hours after antivirals that are active against influenza, like oseltamivir, if you're using that, are stopped. And the antiviral agents shouldn't be administered until at least 14 days after they get that vaccine, unless there's a medical indication to do it sooner. If the antiviral agents are administered in that time frame, so this is that 48 hours up to 14 days after they've gotten the live attenuated influenza vaccine, revaccination needs to happen at least 48 hours after the antivirals are stopped. So you can do it. Just make sure you keep a note for somebody that 48 hours after they finish up the course of antivirals, they need another vaccine. People will love that, I'm sure.
Exactly. And there are other rare instances in which vaccines may be contraindicated or precautions are taken. However, we don't have the time to run through the complete list, so we'll link the chapter out of the Canadian Immunization Guide on contraindications and precautions associated with conditions that might be present in vaccine candidates in the show notes for full details.
In general, the NACI recommends, regardless of the time between the doses, interruption of a vaccine series doesn't require restarting the series because the delays between doses don't result in a reduction in the final antibody concentrations for most of those multi-dose products. But maximum protection might not be attained until they complete the series. Exceptions to this are cholera and traveler's diarrhea vaccine, as well as rabies vaccine for post-exposure prophylaxis, of course. Both of which specialized travel clinics would probably handle, so we're going to leave that there. Objective 2. With parents who are hesitant to vaccinate their children, explore the reasons and counsel them about the risks of deciding against routine immunization of their children.
So I guess we'll just jump right into the elephant of the room, vaccine hesitancy.
That is it. This is the topic all physicians are going to encounter in their offices and outside their offices.
And the CPS offers great practice point articles on their website that will summarize to address vaccine hesitancy with patients and families. But first of all, what is vaccination hesitancy?
This is usually delays in accepting or the refusal of vaccines despite the availability of vaccination services. So what are some variables that might make these people hesitant?
Although not always the case, vaccine hesitancy tends to occur in pockets, such as in non-traditional medical, religious, and underserved communities. Also, something that we don't often think about is that of a healthcare provider's own vaccine status, and that's been shown to influence their patients' confidence in receiving vaccines.
Yep. I tell people about all 12 COVID vaccines I've gotten. Get your vaccines, please.
Parents could be hesitant to vaccinate their children for a number of reasons. So remember that nifty mnemonic that's shoved down our throats during medical school? FIFE, feelings, ideas, functions, expectations. So FIFE their concerns.
It has been shown that understanding and addressing concerns towards vaccine safety, respectfully providing consistent and accurate information about the benefits and risks of the vaccine, and working collaboratively to ensure shared decision-making is going to allow parents to be more comfortable agreeing to vaccine schedules, and it's also going to make sure you maintain the therapeutic relationship, whether or not they take the vaccine.
Very true. Multiple visits for discussions around vaccines issues may be slow, but worth the effort.
And remember to counsel patients about the risks of deciding against routine immunization of their kids. Some of the big things that we want to make sure we mention include things like
serious illness, disability, and even death. Examples include pertussis causing pneumonia, seizures, brain damage, death, meningococcal infections causing meningitis, mumps causing permanent deafness, measles causing encephalitis, brain damage, death, and polio causing paralysis. There is also no treatment or cure for diseases such as measles, polio, and tetanus.
You can mention as well that vaccine preventable diseases are still a threat. There's small numbers such as pertussis, meningococcal disease, and mumps that still do occur in Canada. Measles and polio are also common in other countries. It's a short plane ride away, and unvaccinated children have a much greater chance of getting a vaccine preventable disease than the kids who are vaccinated.
And remember, herd immunity does not guarantee protection for unvaccinated kiddos. If you live in an area with low immunization rates, your child will not be protected through herd immunity. It also does not protect against all vaccines preventable diseases, for instance, tetanus.
The CPS recommends that we also talk about herd immunity as community protection because it might be, and we quote, be off-putting for some parents as they see it implying their child is a cow or a goat. End quote.
Incredible.
Not vaccinating your kid can also put your family, your loved ones, and others who can't receive vaccines at risk. The newborns, the immune deficient patients, and patients with chronic health conditions.
There's also some interest in alternative scheduling for vaccines as opposed to the standard vaccine schedules, whether this is to delay or space out children's vaccinations. As per Immunize BC's website, there is no known benefit to alternative scheduling, only risks such as getting diseases while they're unvaccinated, decreased efficacy of the vaccines, an increased number of visits to your child's healthcare provider, increasing anxiety and needle fear.
Yeah, the last thing we need is kids who are more scared of the healthcare system. We're going to include in the show notes a page out of the Canadian Immunization Guide on routine childhood immunization schedules for infants, for children, and for adults, as well as those who might not have received their immunizations at the planned ages from birth, and those who are at risk due to underlying medical conditions.
So really, to sum it up, just remember to fife, right?
Just fife. Easy. I'll tell you, that's all I learned in med school, and it was enough. Objective 3. Identify patients who will specifically benefit from immunization and ensure it is offered.
Prevention of infection by immunization is not just for the kiddos, but many specific populations will benefit from vaccines for a number of reasons that we'll run through now.
And keep in mind, there are some vaccines that are publicly funded and others that aren't. They're going to vary by province. Always consider this when recommending vaccines for your patients.
As an example, the shingles vaccine is recommended age 50 or over, but is not funded by Nova Scotia and is very expensive out of pocket, about $300. Likewise, in Nova Scotia, if people miss out on the HPV vaccine in school, they'll have to pay out of pocket for it as well. So it's always important to recognize these barriers for the patients.
Well, let's jump into our specific populations.
First, the adults. In recent years, new vaccines such as herpes zoster and HPV have been available for adults. Despite these advances, the vaccine rates for adults in Canada are low. A good tip is setting scheduling record audits on set birthdays to remind yourself of delivering vaccines. Adult vaccinations include the following list.
Keep this in your brain. Diphtheria, tetanus, or Tdap with booster doses recommended every 10 years.
2-dose series of recombinant zoster vaccine recommended for adults 50 years of age or older.
Bivalent or quadrivalent, or if you're fancy, nonavalent HPV vaccine is recommended for women up to and including 26 years of age, and it can be given to those 27 and older who have ongoing risk of exposure. The quadrivalent or nonavalent is recommended for men up to and including 26 years of age as well, and can be administered to men 27 years and older who are at ongoing risk of exposure.
Of course, our seasonal influenza vaccine is recommended annually.
MMR, recommended for adults born on or after 1970 who are susceptible to one or more of the viruses.
Meningococcal vaccine, if it has not been received in adolescence.
1 dose of Tdap if it wasn't previously received, particularly if you have an injury that puts you at risk for tetanus.
The Pneumo P23 vaccine for all adults 65 years or older.
For previously unimmunized adults, a primary series of inactivated poliomyelitis vaccine, IPV, should be provided at the time of immunization with the tetanus and diphtheria toxoid-containing vaccine. They all come in one shot now. It's lovely.
And univalent varicella vaccine is recommended for susceptible adults 18 to 49 years of age.
All right, that's your everyday Joe and Martha grown-ups. Let's talk about pregnant folks. The inactivated vaccines are considered safe when given in pregnancy. Reactions following vaccine with inactivated are usually limited to the injection site. There's no increase in anaphylactic reactions or events that might induce preterm labor. None of that's been observed following immunization with the inactivated vaccines. The vaccines are recommended for the protection of the pregnant individual's health, including the following vaccines.
Inactivated influenza vaccine.
Tdap.
Hep B vaccine if susceptible and with ongoing exposure risks.
Hep A, if there's close contact of a person with Hep A or if they're traveling to an area that's endemic with hepatitis A.
Meningococcal vaccine in an outbreak setting or post-exposure, or if indicated by a medical condition.
Pneumococcal polysaccharide vaccine with or without conjugate vaccine if it's indicated by a medical condition.
And any other inactivated vaccine if indicated by exposure, such as rabies, travel, such as inactivated typhoid vaccine, or medical condition, such as asplenia.
Yeah, the beneficial effects of immunizations during pregnancy for the fetus as well as the newborn infant are pretty well documented. Protective concentrations of the antibodies from the mom are transferred to the fetus across the placenta. This results in increased infant protection in their early postnatal period, which is when we're not vaccinating them. So this is perfect.
Third, let's talk about our premature infants. If in stable clinical condition, regardless of birth weight, the NACI recommends that premature infants should be immunized with age-appropriate doses of vaccine at the same chronological age and according to the same schedule as full-term infants, with some specific exceptions, as outlined in the show notes.
So what does that means don't adjust for their preterm?
Yeah.
Cool. Okay. Patients who have chronic conditions. For the sake of time, we're going to talk about the larger categories here. These include patients with
asplenia or hyposplenia,
autoimmune diseases like lupus, systemic vasculitides, and rheumatoid arthritis.
Big category, cancer.
Anyone with cochlear implants.
Endocrine and metabolic diseases such as diabetes or thyroid disease.
Any chronic heart disease. Get them vaccinated.
Bleeding disorders such as hemophilia.
Anemia. Could be due to sickle cell anemia or thalassemia as well.
Chronic kidney disease.
Chronic liver disease.
COPD.
Last thing you want is COPD is getting pneumonia. Cystic fibrosis as well.
And neurological or neurodevelopmental conditions.
So, for the most part, anyone over 65 and then younger people with specific chronic disease. Love it.
Fifth, immunocompromised patients. As a result from congenital conditions, an illness, or medications that suppress immune function. In general, immunocompromised people are more susceptible to vaccine-preventable infections and may have severe infections. The safety and effectiveness of vaccines in immunocompromised people are determined by the type of immunodeficiency and the degree of immunosuppression.
So what the heck do we mean immunocompromised? Well, think of people with B-cell antibody deficiencies, T and B-cell immunodeficiencies, phagocytic and neutrophilic disorders, complement deficiencies, innate immunity defects, acquired complement deficiency, malignant hematologic or solid cancers, leukemias, lymphomas, etc., hematopoietic stem cell transplant patients, because they'll be on suppressants, HIV infection, and solid organ transplantation. All very good reasons to get vaccinated sooner rather than later.
Lastly, let's not forget about our travelers. Immunization to protect travelers can be life-saving and is a cornerstone of travel health protection. Other protective measures such as sanitation and hygiene, food precautions, insect or animal bite prevention, and injury prevention are also essential for health protection while traveling and are completely complementary to immunization.
A healthcare provider or travel health clinic should be consulted as early as possible. Try and get there at least 4 to 6 weeks before you're traveling or your patient is traveling to provide sufficient time for completion of optimal immunization schedules. Objective 4. Clearly document immunizations given to your patients.
I can't help but wonder, but I think that clearly is a dig to all the doctors writing prescriptions.
Now, this is the reason why we decided recording a podcast is going to do much better than writing a book.
When recording immunization records, there are 3 locations, on paper or electronically, that vaccine providers ought to jot down.
The personal immunization record held by the vaccine recipient or the guardian.
The record maintained by the healthcare provider who administered the vaccine.
And the local, provincial, or territorial immunization registry, if there is one in your area.
Vaccine providers should also provide the following information on each of the above 3 locations.
The brand name of the product given.
Time and date of administration.
The quantity of the dose.
The anatomical site of administration.
The route of administration.
Lot number of the product and expiry date.
And the name and professional designation of the person giving the product. This is a great role for your LPN or whomever's helping you out in the clinic too, if you're doing this in clinic.
Totally. Vaccine providers should also record additional relevant information such as rubella or Hep B serology or TB skin test results in the personal immunization record, as well as the record maintained by the healthcare provider.
With those healthcare provider records, you should also include
all relevant serologic data,
the documentation of any adverse effects following the immunization,
documentation of contraindications or reasons for deferring or withholding immunization,
and other immunization-related documentation like pre-vaccine and physician administration checklists. Objective 5. In patients presenting with suspected infectious disease, assess their immunization status because your differential and consequent treatment in unvaccinated patients is and should be different.
Not sure there's much to say about this that hasn't been already said by the objective title.
Totally. People may present to you with inadequate or no immunization records, so just make sure you try and get the person's immunization records from their previous physician.
Now, routine serologic testing to determine the immunity of children and adults without immunization records is generally not practical, but the following is recommended. Individuals who report incomplete immunizations or lacking adequate documentation of immunizations should be considered unimmunized and started on immunization schedules appropriate for their age and risk factors, as per the recommended immunization schedules talked about earlier.
Nice. Safest way to do it. So if your patient has limited immunization record, try to expand your differential to include vaccine amenable diseases. So suddenly you're considering diphtheria, rubella, pertussis, polio, rotavirus, pneumonias, meningitis, measles, mumps, rubella, chickenpox, hepatitis, HPV, COVID-19, and on and on and on.
One large category that wasn't talked about before is individuals who are newly arriving in Canada. They may be more susceptible to vaccine-preventable diseases because of the lack of effective immunization programs in their country of origin. If people who are newly arriving in Canada are lacking adequate documentation of immunization, they should be also considered unimmunized and started on an immunization schedule appropriate for their age and risk factors.
Objective 6. In patients presenting with suspected infectious disease, do not assume a history of vaccination has provided protection against that disease.
It's so easy to assume that your patients generally have their immunizations record properly filled out and up to date, but as we discussed in the last objective, we should always make sure that a patient's immunizations records are accurate, especially those of a higher risk population. I'm thinking newborns, pregnant individuals, travelers, newcomers, and the list goes on.
The efficacy and effectiveness, they're different I'm told, of a vaccine depends on several factors, including two big ones: the type of vaccine given, as well as the scheduling of the vaccine series. We could go on about every vaccine out there, but we're going to focus on the more common vaccine-preventable conditions. Just know you can find efficacy and effectiveness data on any vaccine in the Canadian Immunization Guide.
So, for pertussis, the vaccine efficacy following the primary series with acellular pertussis vaccines is estimated to be about 85% and approximately 90% following booster immunizations.
And then the duration of protection afforded by the acellular pertussis vaccine is not really known. Available data suggests the protection doesn't significantly decline between that first booster at 18 months and the second booster at 4 to 6 years. So that's nice, but a progressive decline in protection has been observed following that second booster dose.
On to rubella. In clinical trials, 95% or more of vaccine recipients aged 12 months or older developed serological evidence of rubella immunity after a single dose of rubella-containing vaccine.
I'm the duration guy, so I'm going to tell you, following immunization with rubella-containing vaccines, it's not really known. But the studies show that the immunity seems to exceed 20 years. Asymptomatic rubella reinfection manifested by a rise in antibodies has been seen in some vaccine recipients. Asymptomatic reinfection has also been seen in women with naturally acquired immunity associated with very low antibody titers.
For travel-related diseases, it depends on where you end up going, obviously. But if you go on travel.gc.ca, link in the appendix, you can search up the vaccines recommended by destination and go off that list. But to cover two of the big names.
Oh, yellow fever. Sub-Saharan Africa, this is endemic, and it's intermittently epidemic in tropical South America. More than 80% of folks immunized with the yellow fever vaccine develop neutralizing antibodies 10 days after getting vaccinated, and more than 99% will have those by 28 days. In the immunocompetent individual, a single dose of yellow fever vaccine confers lifelong immunity.
And hepatitis A, endemic in many popular destinations such as the Caribbean, South Asia, Sub-Saharan Africa, Central Asia, North Africa, Middle East, and so on. Protective concentrations of antibodies against Hep A develop in 95 to 100% of vaccine recipients after one dose of the vaccine, and nearly 100% seroconvert after receiving 2 doses of vaccines. As well, the protective efficacy of Hep A vaccine when used within 1 week of exposure is approximately 80%.
Oh, I get the travel bug. Get it?
Okay. Sorry, that's a bad joke on the script. We've talked too much.
That does it. Thanks again, Dr. Melissa Power, for peer reviewing this show. Thank you to Sean Wang for reaching out.
Thanks so much, Caleb, for having me on the show. It was a great time, and I look forward to being on more episodes.
Nice. We love to have you. We forgot to shout out Yarmouth. Shout out to Yarmouth and your beautiful lighthouse. It probably has other things. That's just the only thing I know about.
They've got great seafood and better docks.
Nice. All right. This has been it. The Generalist 105 Topics podcast on immunizations. Thanks for coming by. We hope you learned something. There's always more coming. There's more CCFP episodes. There's more obstetrics episodes. There might be a few projects in the works in the background too.
Bye, everyone.
Bye-bye.